We'll start over here.
Hi, this has been a very interesting conference. I just wanted to, this is actually a question about duty to warn. I'm going to use a case that I experienced as a fellow in the 80s when we diagnosed a young boy with Fragile X. And in those days, you could test for carriers in women by doing chromosome analysis, and we knew that it was not perfect. It wouldn't pick up every carrier. But it was still possible. You could certainly do karyotype, like sort of chromosome testing for Fragile X in a male fetus and be pretty sure you were going to pick up cases. But we didn't have the DNA test in those days. And this woman, what we did know was the fact that this woman had a son with Fragile X meant she was a carrier, and she had 3 sisters who were all of childbearing age. And she told me that she would not tell them of this diagnosis. And I was a resident, and I don't think I handled it well, and it's actually bothered me for like 25 years. But the issue is that in the duty to warn, they say it's sort of recognized if there's an imminent risk and if there's something you can do immediately. But the difficulty in a lot of genetic things is that the risk here is that these sisters could have very seriously handicapped sons, that I knew this and that I could offer them something, but the something might actually entail abortion. And I guess I'd like your opinions as to how do we deal with the issue of reproductive risk, or the whole issue that there may actually be an intervention, but the intervention may have moral issues, and would I have ever a right of somehow breaching confidentiality if I knew, like in a situation like that? Is that making sense?
Kate, do you want to start?
Well, I think your case example is a good illustration of why, of my belief that we should work very hard to keep the courts from developing hard and fast rules. And it highlights the nuances of the decision making that the provider needs to make, and it has to do with the evolution of diagnostics, the evolution of therapy, the standard of care, and then very important family issues around disclosure, and also important decisions about how a family might feel about the option of abortion. But in that situation, it would also depend, I think, if we were looking at it, on the age of those daughters and whether, of those children, and whether they were of childbearing age, they were imminently.
These were these women's sisters. They were all of childbearing age.
They were all of childbearing age.
And they were all starting or having their families, so they were imminently at risk.
I think that probably under the law, as it is applied now, you would have discharged your duty, if I were the judge, by counseling that patient and really trying to help her understand, to the best of your ability, the implications for those family members. There might be court situations where it would have come down in a different way, and that's one of the challenges of the law. I think that Dr. Ross can really talk about some of how she would analyze that from an ethical standpoint. She's published a lot on that, so I'd like to turn it over to her.
So it's interesting because the way you framed it was, so the options that I'd be offering these sisters is an option of termination. You would actually be offering them a lot more than the options of termination. You'd be offering the options of not reproducing, surrogate eggs, amniocentesis, and continuing a pregnancy that was negative, and things of that sort. So I think we have to acknowledge that there are a lot of options that people have when they have reproductive information. From an ethical perspective, I don't see a duty to warn in this case. The risk of having a child who is disabled can be a very important risk that some people will want to avoid and that other families will embrace, and it would be something that many women would want. First of all, these women actually have some family history information, right? So the fact that she has a child with severe disabilities, and if she says that they are either autistic or developmentally delayed, a good obstetrician should think, this could be many different things, and we could screen you for some carrier status. And that was true in the 80s and even more so in 2008. So the fact that the family history is known, even if not shared from a reproductive perspective. So I think that these women, so that's one point. The second point is what is an imminent direct risk of harm? I mean, from some perspectives, it's if there were a treatment or a way of changing that genotype while in utero, we might actually say that there was an imminent direct risk of harm. The risk of harm is whether this child is born or not, and I'm not convinced that's always a real imminent direct risk of harm, because from the child's perspective, better to be born disabled than not to be born at all.
Ben?
I mean, I agree with everything that both of the two speakers just said, so I can just say ditto for those two. But then add on a couple other that are, I think, less important but still relevant issues. I think one of the reasons why we would worry about directly intervening with that family is that even though there is this concern about how you possibly could help this family with that information in one variety of ranges of ways, we actually don't know what the impact of that intervention will be. In other words, if you were to have called that sister out of the blue, you don't know what impact that's going to have on her relationship with her sister, on her relationship with you. And while you thought you were doing good, she might be pissed off at you. She may never talk to her sister again. And you have to really, the complexity of what may occur from that breach of confidentiality is hard to predict. And so I'll just leave that as an additional comment.
But having said all that, Ben and I would agree that you should counsel her,
Yep.
counsel her, and continue
Yes.
to counsel her in trying to convince her of the importance of sharing
Absolutely.
that information, because she also doesn't know how her sisters will act,
Right.
whether they'll act to use this information or anything else.
Right.
And I think the comments really underscore, again, the importance of education, 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 and providing patients with the access to the trained physicians and the counselors who have the sophistication to help them sort through these kinds of complex disclosure issues, because we've just, as it's just been outlined here, there were several available options. And Dr. Wilfond is exactly correct. It's very different than Dr. Moore's situation with the psychiatric patient who said, I'm going to kill this woman. And I mean, there is a direct, imminent risk of harm that can be avoided by warning this woman. So Tarasoff is very limited in its application.
Dr. Wallace, did you want to add your impression of the case? Or?
I would totally agree, and I would also say that sometimes when people are receiving results and they're in your office and they say they're not going to share those results with other family members, they may change their minds once they go home and have time to think about it, and you know, and in which case then it gives them the opportunity to share the results on their terms.
I think what bothered me about this case, you've all made me feel better, thank you. But because I was in a training situation, the ongoing care then fell to other physicians. So I probably saw a case in a snapshot as opposed to a video. But thanks a lot. Made me feel better.
Thanks for the question. Right here.
Given that we all carry some gene mutations, I'm wondering if any of you can envision the scenario of a couple going to one of these commercial genome scans, having their genomes scanned, and bringing the results in when pregnant and asking for the same thing on the fetus through a fetal blood sample, and how you would handle that ethically.
That's not a question for the lawyer. Ethics? No.
Well, it's good since I'm a pediatrician, so I don't have the option of easily doing that. A couple of things I would point out is that, first of all, these tests are commercially available, but it doesn't mean that physicians have an obligation to use them. And even though we can even worry about how parents could choose to send in their child's blood disguised as their own blood or their own DNA, it's a little more difficult to get that DNA from your fetus. So in this case, the clinician is a potential gatekeeper. And I would have absolutely no trouble whatsoever at this time if I was actually in that position or an obstetrician was calling me to say, no way today. And for all the reasons about the issue of these constantly changing interpretations, the fact that the understanding of this information is so completely not well understood, and this is just not yet ready for prime time, and I would have no trouble recommending to a particular family that I will not be part of that activity. I don't know, Lainie, if you would agree or not with that.
So let's push Ben and say, okay, Ben, so we didn't really mean prenatal. We wanted to do it with the newborn blood spot. We figured we'd send off the $1,000 genome so that he can't use his pediatric hat to protect him. And so, so the interesting thing about that is if a parent wanted to have a full $1,000, it's actually, what is it, still $200,000 personalized genome, the question is, what do they expect Ben or myself to actually inform them, since so much of it we don't understand. And so what we could do is look for what genes you have that are, quote, bad, and so we can give you a relative risk that this child has a 4.6% increased risk of developing heart disease at age 40. I'm not sure it has any meaning to me today that it would have to those parents. So I'm not sure it would have utility. The question is whether they could have it. So I have to confess, I have, when I was in medical school, one of my friends was doing her genetic fellowship and needed some, quote, normal samples. I said, quote, normal samples, and asked me for whether I would give her 5 cc's for a green top tube. And so I have a picture in my office of my 46 chromosomes, and I always say this is the best picture you'll ever get of me, right? I also, since she needed a male sample, I figured I would be smart, so I went home that night and I gave to my husband. I said, it's time to get a green top sample for what Julie needs it for finishing her residency. And so we actually have the his and her pictures. And they hang on our wall, right? Rather than the wedding picture, we have our gene sample. What do I use with them? Well, I look at our daughters and I say, this is the 7 you have from mommy and this is the 7 you have from daddy. I mean, it's silly. It has no utility. So if a parent wants it, I think at this point they have to understand it's absolutely a frivolous request. It may have a much different meaning in 10 or 20 years from now, but right now it's as frivolous as my having our chromosomes on the living room wall.
Well, I think depending on the results that each of the parents get, it could require a lot of counseling to, as you know, Mark, to go through those results, and probably multiple sessions, which, as we've talked about previously, we don't really have the resources in place. We don't have the genetic counselors or the geneticists to do that kind of counseling. So that could be a difficult problem in the future, because we know we all carry some recessive conditions. And if one or both of those parents finds out what recessive conditions they carry, they're going to want to talk about those things. So.
Well, but if they already have the live child, then we know exactly, if that's what we're really looking for, then we can look for that particular gene in that particular child. And that might not actually be a fishing expedition. That might be looking for one very particular serious illness. I guess I was looking at more as just a genome scan and wanting to know what all the different SNPs mean and whether they're pathological or not. And at this stage, I would be very comfortable to say we don't understand 90% of it.
Definitely.
Yes.
I'd like to know your views on gene patenting. I was very surprised nobody spoke about it. As a lucky Canadian with pseudo-universal health system, we're getting our health system bought by Mairead, for example, who patented the BRCA gene, and by somebody who patented NO. So our healthcare system is being bought by millionaires who want to make more money. And I'm wondering what your views are on patenting genes.
Can we start with a legal understanding? Is it
Yes.
really patentable?
You can't get out of this one,
I
Larry.
can't get out of this one. Well, I think it's a very complicated issue, and unfortunately, the cat is already out of the bag on it. It's happened, and woe that they would have looked at it a little bit differently in the beginning. I think that would be my analysis of it. I had serious concerns when I was looking at those issues, but that you can contrast that with this issue about commercially available genetic testing that ties into the question that the last that was just asked, and whether we should be regulating access to genetic testing at the commercial level without the interface of a healthcare provider. And maybe there's an opportunity where we can do something a little bit proactively, although again, there's a lot of genetic testing that is commercially available now and that is being commercially advertised to individuals without the protections in place from providers. So I'm kind of not directly answering your question, but I'm not quite sure what to do about the patenting issue at this point.
Well, I'm not a lawyer, and I'm certainly not a patent attorney, but actually my father was a patent attorney. And so I'll channel what I think he would have said to this, as best I could do.
This is the pet psychic theme.
What's that?
Sorry.
Yes. No, he's not a cat.
Okay.
I suspect that he rides in the Tour de France, though, right?
Of course, yes.
Yeah.
We see him every year there. So anyway, what he would have said is he always used to point out, in terms of the history of the idea of patents, that essentially patents were really an infringement on civil liberties to protect people who, by not allowing other people to use that patent, what it was really resulting in is that people would be therefore willing to share with the society what they had learned, what they had discovered. And ultimately, through that sharing, there would be broad social benefit. The point, though, is that, as I understood it, and Kate, you can please correct me if you want to add to this, is that the justification for the whole patent system is based upon an assumption, perhaps even an empirical assessment, of whether or not the patents actually provide benefit to society by their existence. So it seems to me part of the way we can answer questions about whether gene patenting is good or bad is by looking at how things would be different, whether if we did or didn't have a system that allowed us to do that.
Well, I think that part of the assumption is, you've outlined the altruistic aspect of the assumption, but I think it also, the patenting laws reflect a perception, at least, that if we don't provide protection for a period of time so that people can recoup the cost of their investment in the research and development that enabled them to get to the point of having these tests, then that research and development will never occur, and our ability to advance technologically will be slowed tremendously. If you look at the experience with the genome, I'm not sure that that bears out, because so much of the initial research and development and unraveling of the genome was done in the public sector, and it was unfortunate the way that it came into the hands of the private sector. Although, again, as you pointed out about your dad, I'm not a patent attorney, and it's not an area I've looked at exhaustively, but that is part of the analysis. It's that economic protection, if you will, that you give people so that they can recoup their upfront costs. You could still probably accomplish that with a little less stringent patent protection.
So here's a case, though, where it's worth looking at how family support groups, for example, have been very instrumental in trying to change the moral landscape. And so I think about Sharon Terry and her work with PXE, which stands for pseudoxanthomatous elasticum, an autosomal recessive condition that affected, I think, all of 2 children at least that she had. And what she decided to do was that she created a support group for everyone with PXE, and she had the families, the affected families, send samples, and she only distributed the samples to researchers who basically signed a contract that if the gene were to be discovered, that it wouldn't be made into this private gene patent that would, in a sense, block off any ability for the affected families to be able to use this test. And by, in a sense, negotiating and working with the researchers, I mean, you couldn't work on this area without her because she had access to all the samples, and there weren't that many. It's an interesting way where the public has sort of shown us how we can push back.
But I also want to clarify, and certainly that's a great example, but it actually shows how it's an empirical question whether patents are useful or not, because in that case, my understanding was that Sharon and her group actually, they hold the patent for that. So they actually were using the patent system, and in their view, the patent system was actually helpful to them for them to accomplish what they believed were their social goods.
Yes, I have a question that I guess relates to duty to warn, but maybe it's the converse of that. Error correction is the way I'd put it. In Birmingham, I run the Huntington's Clinic, so I see a lot of people with Huntington's disease, but there's also a cohort or a family with benign hereditary chorea, which is it's a benign disorder. They have chorea throughout their lives. It typically gets better. The problem is that many of these people will show up in my Huntington's Clinic and because they've been told that they have Huntington's, and some of the older members of the family believe they all have Huntington's disease, even though they clearly don't. So I'll admit freely to being unsophisticated about this, but I will freely tell them, you do not have Huntington's disease, you have benign hereditary chorea. So have I committed an ethical tort here, or is this just another reason why neurologists shouldn't do genetics?
You're concerned that you've committed an ethical tort by informing them of the correct diagnosis for their condition?
But it may have an impact on, maybe somebody's getting disability because they have Huntington's disease or something.
I think that whether or not they collect their disability payments, I think that the benefit of having that clarity, and I remember Dr. Ross talking about you know the diagnosis, and you're in that state of ambiguity. You're negative, you're positive, you're in the state of ambiguity. And anywhere in there that you can add clarity and get them to the correct diagnosis, particularly with a condition as serious and with implications for them and for family members who might perceive a shared risk of such a serious diagnosis, I think it's the right thing to do.
I'm actually glad that you're worried about an ethical tort, because I actually thought you were making a reference to the fact that you've now corrected a colleague who has given them a wrong diagnosis and a really terrible error. People react in all types of ways when they get a diagnosis of Huntington's disease, and some of them may, whether it's suicide, whether it's a decision not to pursue higher education because I'm going to die, whether it's running my visa bill up to the largest debt I can because I won't be around to pay it. And there are a lot of bad decisions that can be made when you have a terminal diagnosis of the sort like Huntington's disease. So I would think that the only thing I could say about you is, you deserve ethical praise, not ethical tort. I'm impressed that you haven't, written letters to all of these docs who are getting the wrong diagnosis, because this can also affect their reproductive decisions. If it takes 20 years for you to see them, they may be past their reproductive age and they may have made decisions based on faulty information. So I think it's critical that you correct it.
Do you feel better now? This is one of the things ethics can do, therapy.
I have one more comment to add to that. I certainly agree with what's been said. When I was at the NIH talking with my genetics colleagues, they used to describe this situation fairly frequently that you described, particularly for rare conditions, where people believe they had a particular rare condition because that's what they had been told by a variety of people, and they see a person who perhaps is the world's expert in this and says, you know what, you really are not one of the 10 families with this condition. And what's challenging is that often for those families, their entire identity has been based upon thinking they were part of that group. And so there turns out there is a fair amount of psychosocial harm that often occurs by saying, you don't have what you thought you had. Even though it might actually be good clinical news, it can still be quite devastating. I don't think they've ever chosen not to make that disclosure, but there is an appreciation that needs to be done delicately. And what you might think being good news may turn out to be challenging news.
And again, your example underscores the importance of education and expanding the access for patients to sophisticated physician geneticists and sophisticated counselors who are going to increase the likelihood that the diagnoses are accurate and that the understanding of what goes along with that diagnosis in terms of risk and options for treatment is accurate.
Dr. Wallace?
I think you're bringing up an additional point, too, that often in genetics clinic or neurology clinic, we see multiple branches of the same family, and we may have information about that family, clinical information or mutation information about that family that they haven't necessarily shared with each other, or we don't even know if they've shared it with each other. So it can be very difficult to walk that fine line and provide the best care for the person that's sitting in front of you, knowing what you know. Very difficult and another ethical dilemma.
Last question.
So my question is regarding duty to warn, but in the context of public safety. So I find this issue more if our education and counseling with the patient is not enough to change their behavior or what we're trying to have them do. So, for example, we see a patient with Huntington's disease and they're clearly symptomatic and they're still driving and they're a school bus driver. What is our obligation as a healthcare provider when we see this potential harm? Because we know as geneticists that their disease is going to progress, but yet, the patient is not yet in acceptance that they should really stop what they're doing because it's a danger not only to themselves, but the children in the bus. Because, this conference, we've all been talking about potential harm, we not test children for so all these things. So I find myself conflicted sometimes when I see patients with this issue, and I'm just crossing my fingers. I hope nothing will happen, but if something will happen, and it's because of the condition, we're left in this position only if they would have known. And I mean they, meaning the employer or whoever, the public. So just want to see what your comments are.
Well, I think that from a legal standpoint, your duties in that situation would really be analyzed around the standard of care for advising and counseling the patient. I don't think that Huntington's disease, unless perhaps you're dealing with children where there's reproductive issues, would be a situation where you'd be able to reach out to the employer or to anyone and disclose. So you need to continue to work with the patient and to counsel them and from a legal standpoint document what you are doing. Now that doesn't address your ethical concern about what happens if, but hopefully, as in the case of the case report that I borrowed from Dr. Wilfond and his group, maintaining persistent contact over time and revisiting the issue with the patient in a sensitive way as their disease progresses will help them come to terms with it and to realize. But right now it's not a situation where there are public health mandates that would require disclosure or even really permit disclosure. When I was listening though, I did think about one thing that I know happens not too infrequently, and that is the sidebar conference with the family member where, it's getting time that maybe this family member shouldn't be driving anymore, and perhaps a call to suggest or trying to get them in for a test, a driver's test, that will yield that result because their license will be revoked. I mean, you could do something like that on the side, depending on your relationship with the family and how much the family knows. But I don't think that you're in a situation where you're either legally obligated or could legally disclose.
So I want to put a little stress on this case, because the fact is there are some cases where you are allowed to disclose, and in some states it's physician disclosure, in other it's the patient. But for example, if somebody has a seizure while driving, in some states, in most states, it's actually that the individual themselves is supposed to report it to the DMV. In about 5 states, if I recall, the physicians are obligated to report. And this brings up several points to bring up. One is that we have to be careful about genetic exceptionalism. There are other reasons why people expose to third parties, including children, to risks of harm, is point one. Point two is then, why do we have laws that specifically pick on somebody who has epilepsy? A diabetic who takes too much insulin or doesn't eat breakfast can also end up in a hypoglycemic state and end up harming the children on the bus as well. So one thing I would argue is we should be getting rid of genetic exceptionalism and worrying about it, duty to warn from that perspective, and thinking about it more from a much more community perspective. And that's why I say it might stress your analysis, because it may start suggesting that we do have a duty to warn, in the sense of if we think that people are exposing other people to harms.
I think that the example that you use, though, the duty regarding epilepsy is a known seizure. And I think if I understood your fact pattern correctly, you're looking down the road and you're worrying that down the road, but you're not quite there yet. And there would even in the public health sort of disclosure setting, I think there would have to be a threshold, so where it's clear that there is this imminent risk of harm to a third person, either with a genetic disease or a non-genetic disease.
That's it. With that, I think I just ask you to join me in thanking the panel and the speakers from earlier in the conference. We've probably raised more questions than we've answered, which is characteristic of, I think, a robust, healthy ethics conversation. There's, I think, a very also healthy research agenda in front of those of you who work in this area. Ben highlighted some of those issues. I think also, I hope that you all will take the Fisher's message home, that there really is important work to be done in understanding the family's perspective in this. And when she said, who stands with us? I think that that's such an important question for those of us who work on this to really try to tackle. I have a few announcements, just a couple before you head off. This time next year, we hope that you had a good time and that you'll come back and join us again. Next year's conference will be on adolescent